completed, 22 years, lady with bilateral nipple discharge. That's what you're talking about, right?
Yes, sir.
Now, I was asking you, when is it significant? If you, first of all, she's young, and we have a term called ANDI. What does that stand for?
Abbreviations of normal breast development.
Of normal
development and involution.
and involution. Very good. She is in this phase, right?
Yes, sir.
It could be any of those aberrations. May not be, but can be. So when you talk, this is called A and B. When you have discharge, it is important to know whether it is single side, single duct, serous, and more importantly spontaneous. Spontaneous, single side, single duct, serous is the highest chance of malignancy. High risk. So 4 S's. What? Can you repeat?
Single side, spontaneous, and serous, single duct.
So you understood what I'm saying? This patient had spontaneous, that is okay, but it is bilateral. So that is one point which is gone against. And then it is not serous.
So unilateral. So right side there was whitish discharge, left side serous discharge.
The discharge is bilateral, but one side is serous, the other side is
Whitish.
whitish is also the same. Milk-like, that's what it says. So this could be related to galactosele, or anything that is related to milk production and release. But it will be bilateral discharge only. Now there is an entity where you are concerned, bloody discharge. One of you mentioned, bloody discharge, the most common cause is not malignancy, it is papilloma of the duct. So duct papilloma. So what is the most common cause of bloody discharge? Duct papilloma, not carcinoma. But carcinoma can produce bloody discharge. You get the point? So it's important to understand the significance of both. Whether it is discharge from the nipples, lump in the breast, pain in the breast, any disorder of the breast, all patients must be subjected to triple assessment. So my first approach would be triple assessment. No confusion about that?
Yes.
And triple assessment I have taught you already. Can you repeat somebody? Yes.
So firstly a good clinical history and examination. Secondly imaging, which can be either ultrasound or mammography. And thirdly core needle biopsy.
Excellent. Very good answer. So good history and examination. Good history, it should include family history. It should include any high risk history also. That is the meaning of good history. Take a serious note of it. It's not that you say no similar complaint in the family. That is not a family history. You take family history of BRCA1 and BRCA2 related genes. What are those? BRCA1 and 2. 2 is related to male breast cancer, but pancreatic cancers, colorectal cancers, prostatic cancers, so all those history are important. BRCA1 is usually associated with breast and ovarian cancer. So they become important. And here you take all the history. Suppose the father had a prostatic cancer, testicular, so take that history. So take that history effectively. Clear? So once you take a good history, then examination. When you say good examination, general examination, yes, and then examine the patient in sitting, supine and reclining position. Why in sitting position? Because you are able to appreciate the level of both nipple areolar complex, any retraction of the nipple, any puckering, any visible deformity, fullness, ulcers, they're better seen in sitting position because of the gravity. And supine position, therefore sitting is ideal for inspection. But not very good for palpation because when you palpate, you can't palpate against the chest wall. So palpation, you need to have the patient in supine position. It is always better to do palpation when the patient is supine because you can palpate the lump against the chest wall and you can also see the inframammary fold, which otherwise the breast covers. You can miss lesions there otherwise. And reclining is a mixture of both. So if you have to have one position only, reclining is the position where you have the advantage of both the positions. It's somewhere in the middle. It's a middle path. Clear?
Yes, sir.
But always examine the normal side first. Why the normal side first?
So so that we can compare the
Yes, one is you can compare with the normal,
texture of the
and the texture of various breasts is different. All breasts are different. So you may have a nodular breast and you think it's diseased, but it may not be. It could be just the usual texture of a particular breast. So how would you know unless you examine the normal breast, you can't. The other thing is what she very correctly said, anything paired in the body. Any organ which is paired in the body, examine the normal side first. Normal limb first, then the other side. This is how you go for it. So, normal side always first. And then the abnormal side. Is that clear?
Yes, sir.
Then you move on to the parts that we discussed. After you examine in good position, do the examination. So inspection, palpation, no percussion, auscultation here. That will be nonsense. You also read in the book for internal memory notes, you percuss in the intercostal spaces lateral to the sternum, but that doesn't yield you anything. It's not a very sensitive test, so it is not recommended. It's not something which you can swear by. Now, there is an extension of clinical examination which is available to all surgeons. What is that? Shreya? Ultrasound. The ultrasound is called a stethoscope of a surgeon now. So now ultrasound examination of axilla and breast is a part of clinical examination of breast. Ultrasound of the thyroid and neck is a clinical examination of thyroid gland. It's an extension only. So you cannot say the state at present, AJCC 8th edition has made it very clear that you can't call an axilla node negative unless you've done an ultrasound. And ultrasound is done by the surgeon himself. You understand now?
Yes, sir.
The other day I was telling you. Now clinicians are learning their own ultrasounds, they're doing it themselves, so they do a better job of it because they know what to look for. Otherwise you are blinded, you have no idea, no clue as to what you're looking for. Naturally, earlier surgeons were lazy, so they did not do it. They should have done it all themselves. Endoscopies, interventions, everything should have been done by surgeons themselves. That would have been better. Anyway, they're coming there, they're getting there. So ultrasound, done. Now she mentioned very correctly about triple assessment, where she has mentioned good history, good examination. I briefly touched it. There is a YouTube video of mine on triple assessment. You can watch it. You can provide the reference to that. Watch it, then you will know. Okay? I don't need to go further. And she very correctly mentioned ultrasound or mammography. I'll add one more, or MRI. What is the indication for doing ultrasound over mammography?
So in young females, when the breast is fatty, and in the aged females, it is parenchymatous.
It's the opposite. young ladies, not females. My students don't call them males, females. We call them gentlemen and ladies. Right? Young ladies with denser breasts, which will look white. So if you try to see a white lesion against white background, you may not be able to appreciate in mammography. So ultrasound is good for them. Secondly, the radiational exposure is a concern, but not a major concern. And the cutoff, some people keep as 35, some keep as 40. So the important thing is density. And when do you do an MRI? When the findings of ultrasound and mammography are equivocal. Equivocal means you're not sure. Then you do MRI. The problem with MRI also you should know.
Highly sensitive.
Very sensitive, highly sensitive, but poorly specific. So it's highly sensitive, but not very specific. So it may light up many lesions, and you may think all of them are disease, but they may not be. So that's why MRI has the problem of specificity. It's very sensitive, but not very specific. And core needle biopsy, you answered very correctly. Why core needle biopsy and why not FNAC? You only will answer.
So the FNAC has high chances of false negatives. Secondly, from core needle biopsy, we can know about the invasiveness of the tumor, and grading of the tumor, and biomarkers of the.
Excellent. That's very good. So you learned from your class. That's what is important. Invasiveness, grading, and biomarkers. I have nothing to add. She's completed it. So core biopsy, needle biopsy is the gold standard. What is the gold standard?
Core needle biopsy.
What is the gold standard?
Core needle biopsy.
What is the gold standard?
Core needle biopsy.
So no FNAC. You should learn it. Clear? So once you do that, you have a diagnosis. And in benign disorders, whenever you're talking, like you talked about the nipple discharge, etc., your purpose is to exclude malignancy. And that will take away the fear from the patient. It will alleviate fear, anxiety, make the patient feel better. Now the specific investigations for ductal discharge. They can be, when you do an ultrasound, you'll have a finding. There can be a duct papilloma, there can be a duct ectasia. So you can add MRI. MRI is useful here, which will tell you about the soft tissue better. You can do ductoscopy. There is a ductoscope available, very fine endoscopic threads which go in and you can cannulate you can actually see the whole picture. Not very commonly used. And the other one is ductography, which you can think is naturally injecting dye and then trying to take a film. Both are not very commonly done. So therefore, if it is a single duct, we try to do what you saw the other day, microdocectomy. We remove the single duct, send it for histopathology. Procedure again, you can see my video on the YouTube. If there are multiple ducts and the lady is past menopause or she is not in the breastfeeding period, then you do what is called Hadfield. What?
Hadfield.
Operation. And this has got modified now. So we call it modified Hadfield operation. What do you do there? This is the nipple areola complex. That's the remaining breast. We give a circumareolar incision. And these are the ducts which become, what is the primary unit of breast? TDLU. What?
TDL.
Terminal duct lobular unit, which has an opening duct and a lobule. That's a single. It's formed of many such units. So the lobule can have malignancy developing lobular carcinoma. Duct can have malignancy developing ductal carcinoma. And if it stays within the duct, it is ductal carcinoma in situ. If it goes outside, it is invasive. Simple. Same thing applies to lobular. And lobular carcinoma in situ is no longer taken as carcinoma. It is taken as harbinger of cancer. So high risk. It is not itself cancer. Okay, clear? So now what do? We made an incision. We dissect out the ductal system completely, free it from the areola, nipple, completely shave it off, remove it along with the lobule. That's the modified Hadfield operation. Naturally, the lady cannot breastfeed now. So you should always take that consent beforehand, and the lady should be in that phase. That's about the nipple discharge. Any question? If it is a pus discharge, it's infection. If it is greenish, it may be fibroadenosis, etc. All these terms are used with a different connotation, but the basic approach to nipple discharge remains as I told you. Any question? What's your name?
Sir, Ishita Singh.
Ishita Singh. You're very good. You remember what is taught. Others can try harder and learn the same thing. Any questions? Shreya? No.